Hi, everyone, and welcome to this very special edition of What's Up, Doc. We are going to be talking about the 2024 guidelines for the management of peripheral artery disease in the legs or the lower extremities. The 2024 guidelines are out, and patients really do need to know what they are before getting treated for PAD. Is still too many patients are getting amputations without knowing their physician is not following society guidance that suggests a vascular evaluation should be performed at the very least, along with at least an attempt to restore inline blood flow prior to amputation. We are also still seeing a few patients as well who have a doctor performing an intervention or even a bypass without following guidelines, suggesting conservative approaches be tried first. So we really got to make sure that the patients understand what the guidance is for the treatment of PAD. The 2024 guidelines are the latest evidence-based recommendations that guide clinicians in the diagnosis and the treatment of leg PAD or lower extremity PAD. And it's across 4 clinical presentation areas. The number 1, asymptomatic disease. Number 2, chronic symptomatic PAD. And then the most serious, chronic limb-threatening ischemia, or CLTI, and acute limb ischemia. And we're just going to cover some of the highlights over the next hour, but one of the most important being the importance of a timely diagnosis. And we're going to find out what that means in actuality. Also, the importance of care being delivered by a multidisciplinary team. So important, especially if you have wounds that won't heal on your foot or on your toe. So get ready to take notes, as the information that interventional radiologist Dr. Mehdi Shishebor is going to provide over the next hour could really make the difference in your life and your limbs. So Dr. Shishebor with University Hospitals in Cleveland, Ohio, thank you so much for joining us.
Thank you very much for having me. I'm looking forward to our discussion.
Me too. So let's just jump right in. Let's just talk about what does guidance actually mean to a doctor, and what are its limitations in practicality or in practice?
Wonderful. Well, the guidelines are a set of recommendations, and I think you emphasized this also in your introduction, that these are a set of recommendations. These are not, as you can imagine, there are no guidelines that can cover every scenario, and every patient is almost a little bit different than the next one that we meet. So these are a set of recommendations, and typically they are designed to be multidisciplinary. They're usually initiated by the American College of Cardiology and the American Heart Association, and they are usually endorsed by a number of other societies, like Society of Cardiac Angiography and Intervention, Society for Vascular Surgery, and many others. So we tend to be very collaborative in nature as it relates to these guidelines. And what we do in these guidelines is that we try to synthesize the literature, synthesize the data, and give some guidance, some recommendation in regards to the diagnosis, treatment, and follow-up of a certain diagnosis. In this situation, peripheral artery disease. We have guidelines for coronary artery disease. We have guidelines for carotid disease. So there are separate guidelines. And the reason they're separate, because these can be very extensive. They could be very time-consuming. And the point of this is that there is a document that is multidisciplinary, that is data-driven, and that is synthesized all the information that's out there and has made some kind of a formal recommendation in a form of a grade. And the grading is important. So the guidelines have 2 types of grading. One is a grading that is based on numerical grading, 1, 2, and 3. And 2 has a 2A and a 2B. And then there is another grading that is based on the evidence that is available out there. And that's A, B, and CE or COE. And I will explain what that means. So when we make these recommendations, we tend to give evidence, and level A evidence means that there's a lot of randomized trials. There is a lot of data and randomized trials comparing one evidence versus a placebo to show their superiority. When there is no evidence, we say CE. CE stands for expert's opinion. And expert opinion means that there is not a lot of data, but the experts who are writing the guidelines are making these recommendations. So that's a weaker recommendation than, let's say, a level A. And then from a numerical standpoint, a level 1 means that is the highest recommendation. So when we say, for example, that a patient with ulcers and gangrene should have a ABI, this is a level 1. That means that every patient should have this. And those are the ones that are the most evidence-based. Similarly, a level 3 is where we say you shouldn't do this. So for example, we say that if a patient is asymptomatic, if the patient doesn't have any symptoms, you shouldn't go and do a bypass. That's a level 3. Those are the hard stop. You shouldn't be doing that. Everything else in the middle is give and take. You know, we empower the doctors to kind of evaluate the patients and make a personalized decision based on the guidelines recommendation and based on the data in regards to what approach they want to take. So that would be a 2A or a 2B. So 1, 2A, 2B, and then level 3.
The recommendations are simply just that. But is there any accountability for these doctors in following the guidelines or deviating from those guidelines?
There is not a formal penalty, to be honest with you, but sometimes, as you know, in the hospitals, we have Q&A and quality meetings where we discuss different conditions. So let's say we had a physician that was doing too many amputations and was not doing revascularization. One of the pieces of evidence we would use in our QIMM meetings, our quality meetings, would be the guidelines. We would bring the guidelines to say, Dr. McNicholas, you know, you're doing a lot of amputations and you're not doing revascularization. Look, the guideline says that this is a class 1 that you should be doing revascularization for patients with ulcer and gangrene. Why are you not doing that? So it could provide that kind of evidence in those kind of circumstances. But as you know, not all hospitals are created equal, and not necessarily there are very robust QIMM meetings at every single hospital. So there is no formal kind of accountability, if you will, based on the guidelines, unfortunately. Sometimes the guidelines can also be brought to the courts. So let's say a physician does something that's very inappropriate, and then the attorneys can bring the guideline and say, hey, Dr. Shishebor, you know, you were supposed to do a revascularization for this patient before amputation, or you were supposed to do an ABI before you amputate this patient. Why didn't you do it? Look at the guideline. The guideline says a level 1 evidence for you to do an ABI for any patient who has an ulcer or gangrene. Why didn't you do it? So they can bring this, in addition to experts that they bring to the court, they can bring the guideline and kind of hold physicians accountable because they were not following the evidence. Where the data is very clear is with the level 1 and level 3. When you get to the middle, is, you know, there is a lot of room for wiggle, you know, and it's harder to make a case. But with level 1 and level 3, there's a lot of evidence and clarity and consensus, and that's where the guidelines can be very powerful.
Right. So the guidelines are there and they can be held up, is what you're saying, in not only court, but also in the form of public opinion, such as the media. Right. And so the doctor in those cases really does have to make sure that they have a good case to explain why they're not following, especially the level 1 recommendations.
That's exactly right. That's exactly right.
Was there anything in terms of the process or any of the guidelines that that really surprised you? Maybe a guideline that was or was not offered in this set?
Yeah, so that's the challenge of the guidelines. As a matter of fact, I've had many mentors that actually refused to participate in the guidelines. As you know, I was one of the writing committee members for the guidelines, and I participated because I think it's important to have a variety of voices represented in the guidelines. We want to make sure that it's a multi-dimensional, multi-societal, and that we are hearing all kinds of voices. And as you know, I'm very passionate about limb salvage and PAD. So we wanted to make sure we have all kinds of voices within the guidelines, and that's why I participated. But the surprises are, one is that sometimes the guidelines are outdated. So as you can imagine, by the time you put all this data together, you go through all these meetings. I mean, this took 2 years. And by the time you get it published, there's been 10 trials that have been presented. And unfortunately, we get the paper, we get the guidelines, but it's behind. So the latest and the greatest is not available in the guidelines. So that's one criticism that comes out. Sometimes if you have conditions, and we deal with that in the vascular disease, where there is a paucity of data. In coronary disease and in heart disease, there is a lot of data. As you know, we do trials with 20,000 patients, 30,000 patients, 50,000 patients. So there's a lot of data in the realm of heart disease. So the guidelines can be very robust because there's a lot of data. When you're dealing with the diseases like PAD, where there has not been a lot of trials, they can be a challenge because the guidelines tend to be conservative when there is no data. But just because there's no data doesn't mean that we don't have patients, and we have to treat our patients. And that's where I find the guidelines a little bit limited, because when there is no data, the guidelines have a hard time making a recommendation because they like to be data driven, but that leaves our patients behind because we don't make recommendations, and that bothers me because we still have to treat the patients, even though we don't have data. It'd be nice to have data, but just because we don't have data, it doesn't mean we don't have to take care of those patients. So those are some of the areas where I think that the guidelines fall short. And then lastly, sometimes the guidelines can become challenging because, as I said, these guidelines are multi-societal, and it's a balance. And sometimes in that balance, I think we can leave some patients behind. And it's like the Washington D.C. With our government. Sometimes in finding that balance, we leave some people behind, and that can happen with the guidelines. That's why I loved how you started the introduction. This is a set of recommendations. This is not hard rules, and that we still need the doctors and the healthcare providers and the entire team to be very dynamic and take a personalized approach to each patient. Every patient is his own person, and we should be very dynamic and very personalized in treating each patient, using the data and the information as a support in making the decision as to what's right and what should be done in regards to diagnosis and treatment and follow-up.
I love what you're saying in terms of we do need an individualized approach because there are those limitations in the guidelines, and we do have to take some of them with a grain of salt. But there still are those guidelines that have that level 1 evidence that we do need to take more seriously and are a little bit more definitive, even today, even 2 years later after you've started, correct?
100%. And this is what we call the low-hanging fruits. Because as you said in your introduction, let's not get into the political part or the things that are not clear. Even if you stuck to the level 1, many of these are not being done. And you mentioned a couple of them, and we can get into it. Simple things like, listen, if you have a patient with ulcers and gangrene, you need to get diagnostic evaluation. You need to do an ultrasound. You need to do an ABI. We know that there are thousands of patients undergoing major amputation, and they don't even get a simple ABI or an ultrasound. So I think we should put our energy into the low-hanging things that are level 1, that everybody has agreed by evidence that these are things that need to be done routinely such as medical therapy, diagnostic testing, revascularization, those kind of things, everybody has agreed that they are level 1. And I think we have a lot of work to do. And I am grateful to you and your entire team for taking this on and educating our patients and our communities. Let's at least get to the level 1. Once we're done with the level 1, then we can worry about the other stuff that are not as clear.
I agree. Let's dive right into this, the level 1, and let's start with a very important point that you expressed, which is the timely diagnosis. What do the guidelines state about timely diagnosis? Who's accountable for ensuring a timely diagnosis? And what does this mean for patients who need to advocate for their rights?
So that's a wonderful question. And thank you, Kim, for asking that question, because at the end of the day, if we don't make the diagnosis, as they say, the rest is history. Meaning that, unfortunately, the patient doesn't get the treatment if we don't make the diagnosis. And with all the technologies and resources that we have out there, both medically and with devices, we will lose the opportunity to treat our patients. So it is definitely an opportunity for us to be able to diagnose the patients in a timely fashion. So the guideline is very clear, very clear. They say that you need to perform an ABI or an ultrasound or a CAT scan, some kind of imaging, to diagnose patients that have PAD with ulcers and gangrene. So anybody that is CLI, we call it, as you know, and your participants are familiar with this terminology. So these are patients that have ulcers and gangrene. Many of them are diabetic, that are at risk of losing their leg. The guidelines make it very clear, is a level 1. Every patient that has any form of an ulcer or gangrene, they should be getting an ABI or a duplex ultrasound or both, or get a CAT scan or an angiogram, something, so that we can make the diagnosis of whether they have vascular disease or not. That's one. The second point is that anybody that has symptoms with claudication, so anybody that doesn't have an ulcer or gangrene, but when they walk, they get the calf pain. And then when they rest, the pain goes away. We call those patients those that have claudication, that PAD, that blockages that cause ischemia when they walk. Those patients should be evaluated with an ABI, a routine ABI. If the ABI is non-diagnostic, meaning that they have non-compressible arteries, or for some reason is not accurate, they recommend an exercise ABI for those patients. That's all level 1. So when we do ABI for PAD, normally it's done at rest. But our patients don't have pain at rest. When they're sitting, they don't have pain. They only have pain when they walk. That's the definition of claudication. Claudication is when you walk and you get the calf tightness, and when you rest, it goes away. So by definition, if you just do a rest ABI, you are not getting a thorough assessment of what the perfusion to the leg is when the patient is having pain. So the guidelines make a recommendation, that a 2A recommendation, you can do exercise ABI to truly assess what the patient is perfusing, what is their number when they are having claudication. So again, the guideline is very aggressive with diagnosis of PAD. And there's also something else that I want your audience to be aware of, and this is very important, Kim. PAD is the strongest predictor of mortality and cardiovascular events than any other risk factor that we evaluate. So when we go to our doctors, they say, do you have high blood pressure? Do you have diabetes? Do you have family history of heart disease? Do you have high cholesterol? Do you have elevated Lp(a) and all kinds of things? Of all of those things, the strongest predictor is PAD. If you have PAD, your risks are very high. And even if you don't have symptoms, even if you have no symptoms, you have no ulcers, no gangrene, no pain when you walk, just you've been diagnosed with PAD, that's a very powerful kind of a risk factor to know. So if you get an ABI and you have an abnormal ABI, we know that your LDL cholesterol, for example, should be less than 70. PAD is equivalent to diabetes and coronary disease. So when I see a patient that has had a heart attack And I see another patient who's never had a heart attack and has never had a symptom, but their ABI is less than 0.9. To me, they are the same. I see them with the same lens from a standpoint of risk and future events. And that's very powerful because we can be very proactive, identify patients at risk of having bad outcomes over time, and be aggressive with risk factor modification. Get their LDL below 70, get them to do exercise, quit smoking, control their hypertension, and so on and so forth. There is so much that we can do. I mean, we can get into it, but there is a lot of things that PAD is a very powerful predictors of bad outcomes, and we need to educate and diagnose our patients.
With PAD being a clear indication of a person's risk for a heart attack, are there any recommendations in there for patients who have PAD for a doctor to recommend that they go for advanced cardiac testing as well?
That's a great question. So there are a lot of us out there now. The evidence is weak. So here we go. Again, going back to the guidelines and the evidence and the data, because there's always a lag, because the evidence takes many years to build. It's not like there's not the funding and the support is not very strong sometimes. As we're trying to build the evidence, but we know. I mean, you asked a beautiful question. In my practice, so now we are not talking about the guidelines. This is Mehdi Shishebor. In my practice, if you are a patient that has PAD, in my mind, and there's a lot of evidence for this, by the way, you are at higher risk of having coronary disease. So I send a lot of those patients for calcium score, to be honest with you. And a lot of the patients that have PAD, they're not very active. Guess what? Because they get pain when they walk. So they indirectly modify their activity level because they don't want to have pain. They don't even know they're doing it. So I give you an example. I have a lot of patients that play golf. They come see me. I ask them, do you have any symptoms? Do you have any chest pain or shortness of breath? No, I'm doing great. I said, well, do you take the cart or do you walk? You play 18 hole. They said, I take the cart. I said, did you take the cart 2 years ago? They said, no, I used to walk. Well, why do you take the cart now? Well, it's easier, Dr. She said, well, I don't know. I would get tired. Well, that's symptoms. Why do you get tired? And then when I pushed, I was getting tired, a little bit short of breath. So I just take the cart now. I just thought I was getting, I was not fit. Well, why are you not fit? Well, because you're changing your activity level. See how, being a doctor is like cooking. You can just throw 2 eggs in a pan and just make a quick omelet, or you can be sophisticated and make a nice pasta. And, it's like anything else in life that we do, right? We can be very elegant and very sophisticated in your approach, or you can be just warming up a frozen food, So, and medicine is the same. Now, the truth is that the consequences are big. If you eat a bad food, like not a delicious meal is okay. Well, it wasn't delicious. But if you don't make the right diagnosis, patient can have a heart attack. They can have a bad outcome. So in our field, having sophisticated doctors that can delineate and dissect the diagnosis is very important. So to answer your question, yes, in my practice, I am very aggressive in doing coronary evaluation, even in asymptomatic patients who have PAD, because there is a lot of evidence that PAD and coronary disease, they go together, they're married together. And that, we need to be more vigilant in identifying coronary disease in patients with PAD.
Yeah, I was just having a conversation with a university cardiologist who said that fatigue is the new angina, and you need to ask the right questions to get the right answers from patients. And I think that that's not only perfect for the heart, but also for the legs. And when people end up calling, some PAD people asymptomatic, I always say, well, how are you defining those symptoms? Because there have been patients that we have worked with at the Global PAD Association who have been, stated as being asymptomatic. But when you talk to him or talk to her, just as you were saying, You asked the right question about the golf cart and what did you do 2 years ago? It's the same thing. Some people don't realize that over time they're doing less and less and less and less in order to prevent the onset of some sort of pain, some sort of symptom. And so you have to really ask in-depth questions to understand, well, are they truly asymptomatic, or are they just completely modifying their lifestyle so that they don't become symptomatic?
It's so common. It happens to us. It happens to me. I'll be honest with you. In the winter time, I don't bike because of the weather here in Cleveland. It's icy and cold and not very pleasant for road biking. When the season opens for biking, I want to be honest with you. My fitness is totally different. And I don't think of it. It's not like it hits me. I'm like, oh my God, I am totally out of shape, from a standpoint of my activity, but I don't think of it the whole winter time because I'm able to do my routine daily activity because I'm not pushing myself the way I do when I get on a road bike. And I think this is happening a lot with our patients. I think you hit a very important point here that we as humans are very smart and we subconsciously tend to change our activity level without even realizing that we are doing it.
Yep, I agree. So I want to go through the different subsets of PAD and the indications for and types of treatment for each. And, we can start with asymptomatic, but can we do a quick overview of the 4 subsets and just brush over just the different types of treatments that are standard for each? And then we're going to dig into the conservative approach a little bit deeper after that. But let's start with the 4 subsets. And would you mind just going through just an overview of the treatment indications?
So think of PAD and CAD, coronary artery disease, exactly the same, to be honest. There are thousands and millions of people out there that have blockages in their heart. They have no idea. They don't even know that they have blockages. Unfortunately, sometimes these patients end up with a cardiac arrest and they die. Many of us have had family members. My own father had a heart attack and died from it. We had no idea he had heart disease. He was 54 years old. So this is not, these are very similar disease processes, PAD and CAD. So when it comes to PAD, the first subset is the asymptomatic, the people that we have no idea that they are out there. That's one subset. And under that subset, there is a cohort that we don't know they have PAD because they have never been tested. And there is a group that they have been tested and we know they have PAD. So let's call them asymptomatic. I would say even there's 2 categories. I would say the unknown and then the asymptomatic. So we know they have PAD, but they have no symptoms. Then we have the category of symptomatic PAD, which is the claudication. That's the group of patients that I said. These are patients that don't have ulcers or gangrene. These are people that they walk, they get pain, they get symptoms, they sit, they rest, the pain goes away. So that's symptomatic PAD. Then we have a third group that we call chronic limb threatening ischemia, CLTI, or critical limb ischemia, CLI. The nomenclature, as you know, Kim, has changed a little bit here and there, but it's all the same. These are patients that have ulcers and gangrene. They have a skin breakdown. Many of them, 60, 70% of them are diabetic. Some of them have chronic kidney disease. Some of them have both. Some of them are on dialysis. These are patients that have a lot of risk factors. They have hypertension, they have smoking history, or they are active smokers, they have high cholesterol, diabetes, like I said, so on and so forth. These are the CLI or CLTI patients. That's the third category. And then the fourth category is what we call the acute limb. This is a very special category. We compare this to acute MI, when people have a heart attack. That's our heart attack of the leg. These are patients that suddenly something has happened to their leg, acutely, suddenly, within the last 2 weeks. And they have become now symptomatic with lack of blood flow. These are patients that are eminently at risk of losing their leg. And they need immediate, urgent, emergent attention to save their leg. So those are the 4 categories: asymptomatic PAD, symptomatic PAD, claudication, critical limb ischemia, people with ulcers and gangrene, and then those with acute limb, those that suddenly present with a sudden pain and discomfort in the leg, and they have a sudden event that has caused cessation of blood flow to the leg, and they need immediate attention and revascularization.
So the asymptomatic and symptomatic, let's start there because it's consistent, conservative approach, right? The guidelines address the use of effective medical therapies for patients with asymptomatic and, for intermittent claudican symptomatic PAD to prevent adverse both cardiovascular and or limb events. So can you walk us through those antiplatelet to statin to vasodilator therapies and what the guidelines state?
Absolutely. So here's the deal. As I mentioned earlier, Kim, the PAD is a very, very strong predictor of poor cardiovascular outcomes. So having a heart attack, dying, having a heart failure, those kind of things. So the first thing we want to do, whether you are symptomatic or asymptomatic, if you are diagnosed with PAD, you got to do the following. Number one, you got to have a serious lifestyle modification. So if you're eating a lot of meat and chicken, if you're eating a lot of grease and fatty food, if you don't have a Mediterranean style diet, you got to work on that. Number two, we want to encourage you to exercise. And we typically say 5 to 6 days, 30 minutes of a robust level of aerobic exercise. So either rapid walking or even some kind of a jogging or running. And we are learning more and more that the more vigorous the exercise, the more you live, the more longevity. The third one goes back to the routine stuff. So hypertension. We want your blood pressure to be less than 130 systolic and less than 80 diastolic. That's the blood pressure. The fourth is your cholesterol, is LDL. We know that LDL is the building block of atherosclerosis. Without LDL, we cannot clog our arteries. Let's be honest. So we need to reduce the LDL. So we want that to be less than 70. And many of us, honestly, for ourselves and for our family members, we want it to be 30 and 40. I want my LDL to be 30 and 40. I want to be honest with you. Like that, to me, I think is ideal to have 30 or 40. So we want to be aggressive with the statin therapy. And right now, there are a lot of therapies that are available, not only with the statins, but we have PCSK9, we have ezetimibe, we have many different drugs. And we are believing more and more that even for cholesterol, we need to do polytherapy, just like blood pressure. When patient comes to us with hypertension, we typically do maybe 2 or 3 drugs to control it, medications to control it. We are thinking that maybe the same is good approach with cholesterol, because some of these drugs like cholesterol medications can have side effects. So if you're giving a high dose, people can get muscle pain. Maybe it's better to have a lower dose of cholesterol lowering drugs like statins and then add ezetimibe on top of that, or add PCSK9 on top of that. So there's a lot of stuff which is hard to get through in an hour, but there is a lot of nuances to be able to do that. But definitely we want to get the cholesterol down. So hypertension, cholesterol. If you're smoking, there needs to be a serious conversation with your doctor. And we need to get you to a smoking cessation clinic. We need to do everything we can to help you quit smoking. And then we get to some of the other categories. These are all level 1. So that was kind of the overview of all the level 1. Then we get to some 2A and 2B recommendations. So what are some of the 2A and 2B, just to throw it out there? For example, Lp(a). We know that this is a marker that has a very poor prognosis, and we think that it could be informative. So that's something that maybe we check. Now, we don't have any specific therapies for it, but there are some new novel therapies that may be coming very soon. The other one is CRP, C-reactive protein. We know it's an inflammatory marker, and it can be very useful. And there are some drugs that can reduce that. So we want to know a little bit about that. Homocysteine, another one. We used to check that a lot in the past, homocysteine. We stopped checking it because the trials were not that positive, but some people still do check it. And, some people still prescribe folate for this, folic acid, but many people don't. The guidelines didn't give it a high recommendation because the data is becoming weak. But again, once you go through the ones, but there's so many things you can do as a level 1 that you don't even need to worry about the 2As and the 2Bs, to be honest with you. But if you have done all the ones, there are some tweaks that you can do in the 2A and 2B to try to even improve the risk even a little bit more. Let me stop here, see if you think there are any questions to discuss.
I was going to mention, I'm glad you mentioned the homocysteine, because even the American Heart Association does in fact mention the MTHFR gene mutation, which can lead to those high homocysteine levels. That is something that actually I have. It's also something that my dad had. I was indicated to go get, checked for it because my dad did. And what was interesting is once he realized he had this gene mutation, his dietitian put him on and he had high homocysteine because of it. She described homocysteine as if you have too high levels, it's like nails on your artery walls, leading to a lot of damage, which can trigger the inflammatory response and those small LDL particles eking into that damage and pushing that wall out. That's how she described it to us. And as soon as we put my dad on, therapy for that, the folate, the liposomal B vitamins underneath the tongue, his homocysteine levels significantly dropped. And it seemed to be a better outcome, and the progression of his disease, his heart disease, seemed to have stalled significantly. And this was according to his cardiologist. So I don't know what evidence or what folks they're testing, but I know, in fact, from my dad, and it's something that we have a real serious discussion with a lot of our patients about. It's that MTHFR and those homocysteine levels. So I'm a firm believer in that, just based on my own experience.
Absolutely. So there are other, and that's again goes back to the earlier conversation we had, that there's a lot of pressure in medicine, Kim, to see patients quickly. If you're saying, we are supposed to see patients in 10 minutes, 15 minutes. And you can imagine, we look at this discussion, there is so many things, there's so many nuances, there's so many opportunities. So you need sophisticated doctors that can delineate all these other opportunities, but also not to forget about the low-hanging fruit, because again, it is nice to deal with the homocysteine and Lp(a) and CRP and some of these other more advanced risk factors, but just the basic stuff is still not being done. So we need to really work together in trying to educate our patients that they demand that, listen, what is my LDL? Why isn't it not 60? What can I do to get my LDL to 60? Because there are some doctors out there that they're still practice with LDLs of 100 and 120 and 130. So the more that our patients are informed, the more they can demand and ask questions. And that's why I do these webinars, to be honest with you, because I am very passionate in educating our patients. I think we have to empower our patients to seek the best care that they can get.
I just wish that the guidelines would have included a little bit more definitive in terms, recommendations in terms of, if you have a patient that's ending up with a revolving door of treatments, that it's a requirement that the doctors sit back and there should be a checklist of all of these, even level 2 and beyond, to say, okay, we checked this, we did this, we checked this, we did this. Okay, we need to go to the next levels to find out, why is this revolving door of treatments continuing and continuing? We got to get to a deeper level, because there are a lot of patients out there that are the exceptions, in a sense, to the rule.
Absolutely. Absolutely. And unfortunately, this comes all down to execution, right? It's all nice that we have the guidelines, we need it. It's nice that, we have the data. It's nice that we do all these clinical trials and we spend millions of dollars learning and identifying what works and what doesn't work. But at the end of the day, if we don't do the execution and deliver this to our patients, either because the drugs are too expensive, or because somebody didn't have these conversations with our patients and didn't do the checklist, or because our patients didn't do the drugs because they're too complicated, and they forget to do it, then we didn't do our job. So there's a lot of resources that goes to getting all the information, but at the end, it's all about execution and making sure that, we are bringing all these therapies and all these opportunities to our patients.
And one of that I didn't hear you mention the vasodilators, the pletols. I know that they have been in Society for Vascular Surgery guidelines. Are they in these guidelines to talk about the use of those types of drugs?
Yeah, the pletol is a little bit tricky. So the pletol, as you know, we prescribe it only for symptomatic PAD. And pletol gets a good recommendation, a class 1 recommendation, because there is some data that if you have symptomatic PAD, not asymptomatic, symptomatic PAD, that, it can improve your walking distance. The problem with pletol is that there's a lot of side effects. It's contraindicated in patients with heart failure. It can also cause a lot of GI upsetness. It needs to be titrated up slowly so that patients don't get side effect from it. My own personal experience with this drug has not been great, to be honest with you. I do have a good number of patients that are taking it, don't get me wrong, but it's not the holy grail. Unfortunately, because we don't have too many drugs, we are stuck with it, and this is the only one that we have. So we use it, we talk about it a lot, and in the guidelines, it gets a class 1 recommendation, but the reality is that it's not a very effective drug. The one thing that maybe we should emphasize is also supervised exercise therapy for PAD. And I think that one is a very huge one. And I think that every patient that has symptomatic PAD should be getting supervised exercise program for PAD, in addition to aggressive medical therapy and revascularization. Symptomatic.
So I do want to talk about walking as medicine. This, I agree, is a critical area that I still think needs a much harder hitting requirement. Doctors tell patients to walk, 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 but very few patients have access to, as in the Netherlands, to a supervised exercise therapy program. And I don't see that ever changing because there aren't even enough cardiac rehab programs to go around. Even for my dad, it took him 3 months to even get on a waiting list to get into an exercise therapy program in our program. So, not even that. I mean, these patients aren't even getting any direction at all in terms of even how to walk effectively, to grow their collateral vessels, to reroute that blood flow around any sort of blockages. So I want to talk about the guidelines because when I was reading them, they mentioned that yes, supervised exercise therapy is the holy grail. And it's only the holy grail, though, for a short amount of time. I mean, how many patients actually continue with what they learned in those 3 months and with the regimen that they performed in those 3 months? Because most, especially in the low-income communities, don't have their own treadmills, especially at home. And some patients say it's a lot easier for them to walk on a treadmill than it is, on the ground. So they're just not going to continue with that therapy. So the next best is really a structured program, and especially ones that are community-based or home-based. And the reason I really bring this up and I'm emphasizing this is because we have a structured program through the Global PAD Association. And a doctor just last week asked if it was actually an approved structured exercise therapy program. Do the guidelines offer any parameters for that other than the fact that a patient needs to have 3 months of documented exercise therapy, whether it's structured or supervised?
Yes. So great points. I love every point you made. They're right on. They're all very correct and very right on. So number one is that supervised exercise therapy for PAD, even though now is reimbursed, I mean, at least by Medicare and by some of the third-party payers, which is, by the way, it took us decades to get it to that point, is only for 3 months. And we know anything that you do for 3 months only lasts for 3 months, maybe 4 months. And if you stop doing it, it's like diet. If you diet for 3 months and then you don't do it, you're going to rebound, right? I mean, you need to do, these are things, habits that we need to carry on for life. You cannot exercise for 3 months and be like, okay, great, I'm done. I'm now good. My arteries are perfect. It doesn't unfortunately work like that. So that's one of my pet peeves, to be honest with you, because these programs, while they work while you're doing it. So going back to your point, we need to have a sustainable programs that patients can engage with for life, for years and for life. So that's at least a challenge that you brought up, and I think you're right on. The second thing is that it's not easy to find them. And as you said, many areas in the United States do not have it. And even the ones that claim have it, they don't do it correctly. So you're correct. So we have that challenge. So that leaves us, well, what can we do? So the challenge with a structured, and the guidelines do give a higher recommendation for a structured program versus a non-structured program. And I think that anything is better than nothing. The challenge that I find is exactly what you said, is how many of our patients have the capabilities to even do the structured program themselves, because they don't have a treadmill. They don't have a membership in the gym. I mean, we're talking about patients that get PAD. We know that PAD is more prevalent in a more disadvantaged patients, people that come from a lower socioeconomic status, people that live in geographic areas that don't have the amenities for walking and outdoor activities. So with all of that, I don't want to just focus on the negatives, but there are a lot of challenges. But yes, so to answer your question, the structured exercise program is better than a non-structured program. We should definitely advocate for these and have our patients follow with this kind of a format of structured exercise. But understand that even that is going to be very limited. There are some, kind of a virtual telemedicine directed exercise and rehab programs that are coming out. As you know, there's many of them coming out. Even Amazon has a program now, I heard, and there are many other prominent organizations that are coming out with rehab, cardiac, and PAD. And hopefully there are ways that we can encourage our patients remotely to be able to exercise, so we can elevate structural exercise programs by having a kind of a virtual oversight, so that we can guide our patients to do it in outdoor facilities or maybe at home if they can do it.
So when you're talking about structured, what are those parameters? Is it just that you have to have a start date and a finish date with someone looking at some data? Or are there a certain number of televisits that they need to do with a patient throughout, for the duration of those 3 months?
Yes.
What are the parameters around?
Yes. So we try to emulate, the supervised exercise program at home, basically, except that you're not going to a facility. You do not, somebody's not putting EKGs and monitors on you. Somebody is not monitoring you and taking information down. I mean, that's really supervised exercise, right? We follow the protocols about, the inclines and the speed and, all of that. So some of that is hard to do it in a structured program because patients may not have a treadmill. So the format is very similar to a supervised exercise program, but is less well defined, in a sense that there is not a formality to it. So that's point number one. Formality meaning that we don't have the monitors and you don't have somebody there to supervise you. But the bottom line is that we want to do this similar kind of a protocol, if you will, as we would do in an exercise program, with the duration and the period of time that the patients are doing this. Now, what is interesting is that if the virtual comes in, I think we can elevate that. And I think that's where the future hopefully can be a middle ground, where we have somebody virtually actually engaging with the patient to make sure that they are doing it. Because one of our challenges is that when we tell the patients to do it, they don't do it. Just like we tell them to take your cholesterol medication and they don't take it. And to be honest with you, it's hard for me to judge because I told you, I have a very strong family history of PAD. I mean, of coronary disease, not PAD, coronary disease. My dad died of heart attack. As I said, my brother had quadruple bypass at the age of 58. So I was told I need to take statins. It's not easy to take pills. I want to be honest with you. So I'm very, I've experienced this myself. So I have a lot of understanding of my patients, because my Lipitor is sitting right in front of my sink, at home, but I don't take it routinely. I forget. And it's very hard for me to judge my patients, because even though I know the circumstances, I know how important it is for me. I give lectures about how important it is to take your drugs. And I scream and yell to my patients, I forget myself. So while it's easy to tell our patients, please walk, they don't do it. They don't do it. So I think that hopefully with the virtual structured programs, we can have a more of an effective approach to this, and we can get more of our patients to commit to walking.
And we just released our app on Friday, and you have to be walking. It'll let you know if I mean, if you're not walking, you get notified. And if you just turn on the timers, if you're walking, no, it's gonna have it where you need to track your steps. And it's not just using a Fitbit where you can just go wave it around and get those steps. It uses your actual phone, which is a little bit more conservative. So you're really fighting to get those steps logged into the phone. So I'll have to show that to you at some point, because I'm really curious. I want to make sure that it does fit that area of structure so that doctors are comfortable across the board using it, because it is a free dashboard for the doctors to monitor their own patients versus outsourcing it to someone else. And you don't need extra people. You just have your own people, and it provides for a more productive conversation during your consults and follow-ups with the patients, because you have walking data and you can actually see exactly what they're doing, and the symptom tracker to see what they're complaining about or experiencing during those walking sessions, which is most important. So we'll have to talk about that later.
I love that. No, I love that. I love to learn more about that. I think it's fantastic, and it's extremely important to empower our patients, and resources like this, Kim, are life-changing, to be honest with you. We just need a little push, hopefully, a little push, and we can get our patients to be able to modify their risks and obviously get them to exercise.
Exactly. And we're democratizing access. We've had great companies come in to help make it possible. So we're offering it at no cost to doctors or patients to make sure that we can roll it out there and have a direct impact immediately. But I know we only have a few more minutes. You have patients to see today, but according to the guidelines, what do they offer clinicians in terms of determining when intermittent claudicants, these intermittent claudicants that would fit into the category for conservative therapy, lifestyle modifications, walking, medicine, etc., when they should be allowed an intervention? For example, if they can't reap the benefits of a cardiac rehab program for their heart because they keep having to stop and rest every few minutes.
So the guidelines give a class one recommendation to patients that have failed exercise therapy and medical therapy for PAD, for claudication, and for revascularization. And actually, they give a higher recommendation to endovascular revascularization than bypass. They give a class 1 for endovascular, and they give a class 2A for bypass, because bypass is more invasive. So for claudication, the guidelines actually are more friendlier to endovascular approach because it's less invasive, and because of that, it's a friendlier recommendation for endovascular. But again, we want to make sure that we are doing everything first, right? Going back to your point, if you're smoking 2 packs a day and you are not doing any exercise, and your LDL is 180, and your blood pressure is 170, is the stent going to help you? No. And I mean, let's be honest, it's not going to help. And the stent is going to close. And you're going to get it, and then people say endovascular doesn't work, but that's not true. So the bottom line is that we need to get our patients optimized with all the things we just talked about for the past hour. And then if the patient still has symptoms, we want to relieve those symptoms, because we want our patients to walk. We want them to be able to be effective members of the community. We want them to be able to do their jobs and take their dogs out for a walk and chase their grandchildren and do the things that they want to do. But we have to do both. We have to do the risk factor modification, address the exercise component that we just talked about, and then, if necessary, we can offer them revascularization.
So you say that they're weighing a little bit more heavily towards endovascular, especially for the earlier stage, and probably mainly considered lifestyle limiting claudicants. Right. But what are the indications for intervention versus bypass for beyond? Because we still have a good portion, a lot of patients that are offered bypasses, frontline therapy beyond conservative approaches. So if walking feels conservative, they never even go in. And I always say to patients, well, wouldn't you want someone to at least go in with a wire and balloon, pump in the contrast fluid, and I even say my non-negotiable is the use of intravascular ultrasound to really get a better idea of the morphology of the plaque, because sometimes I've seen like a CT angiogram can have some limitations in certain areas where it looks as though you can't get through. It looks as though there's this really tough blockage. And then you go in and it's just mush. You get through the cap and then they poke the wire right through and go right through this 100% blockage. Absolutely no problem.
Yes.
So I get concerned when when I see patients that, and I say, hey, you might want to just get a second opinion before going straight to an invasive procedure, especially if you're a patient with comorbidities such as diabetes.
Well, Kim, I think you are speaking of something that's very important. I think in healthcare, we take the recommendations for granted and take it at the face value. When you want to, I tell my friends and my patients all the time. So when you want to buy a car, you never just walk to a dealership and the first car that you see, you just buy it. Let's be honest. You're going to do some search. You're going to talk to a couple of friends. You may go to a few dealerships. You're going to look at the blue book, the green book, I don't know what books they have these days. But anyway, you're going to do you do your homework. Now you talk about your body. So you should always ask for a second opinion, especially if it's something that's bothering you, that you're suffering from, or if you're going to lose your leg, for God's sake. So I am very passionate about second opinions when it comes to healthcare, and even third opinions to get all the facts and then make a educated decision yourself. Make a shared decision making, we call it, so that you have all the information and you know what all the options are, and you can make a educated, knowledgeable decision in regards to how you want to proceed. So I think you're hitting that on that. I mean, it's hard to make general statements. There are some situations that surgery may be better. But I agree with you that unfortunately, a lot of time it depends, there is a lot of heterogeneity of care. So if you come to me because I don't do surgery, you may get endovascular. If you go to somebody else that doesn't do endovascular, you may get surgery. And it shouldn't be like that. It should be that, somebody discusses all the options with you, and then you make a decision. You say, you know what, maybe doing it with wires and balloons is a little bit less riskier, is a good first step. As long as the doctor is knowledgeable and knows what they're doing, maybe I want to try this first. Now, if that doesn't work, maybe then bypass can be a second option because that's a little bit more invasive. And I think that's what the guidelines are saying. The guidelines are saying that endo is a little bit more invasive. Maybe that's a better first option for claudication. And then if that doesn't work, then we can consider surgery as a 2A. But just because the guideline says it's one, it doesn't mean that all endovascular is created equal, right? So it's just that you need to find the right doctor, someone that has a good understanding, somebody that has a high quality, and that you have vetted and make sure that you have gotten a second or third opinion in regards to that what's going to be done is going to be done correctly and effectively for you.
I think that's so important. I don't know if you just have a few more minutes here just to square away a few loaded questions. But previous society guidelines from the AHA and SVS indicate that a vascular evaluation, we touched on this at the beginning, that a vascular evaluation to restore inline flow should be performed prior to amputation. But as you know, despite that more than 60% of all amputations are being performed without either a vascular evaluation or an attempt to restore inline flow prior to amputation. What is the 2024 statement or guidance for pre-amputation protocols?
100%.
Anything definitive?
Yes, 100% is a class 1 indication in the guidelines that every single patient that is scheduled to undergo amputation should have some form of a vascular evaluation, some form. Whether you want to do ultrasound, do a duplex ultrasound. You want to do ABI, do ABI. You want to do a CAT scan, do a CT angiogram, do a CT angiogram. Whatever it is, MRI, do MRA. If you want to do an angiogram, do an angiogram. But we should not be amputating the patients without understanding what is the level of the blockage, what is the perfusion looks like, and that is there anything that can be done for them? Because even if they need an amputation, the level of the amputation, there's a lot of stuff we don't have time right now, but maybe next time we can talk about that, because it's not just, okay, there's a difference between getting a toe amputated whether you're getting a below knee amputation or getting an above knee amputation. These are totally different amputations. So even when you have agreed that we need an amputation, the level of the amputation and the functionality of the amputation is extremely important. And having an understanding of the blood flow and whether that kind of amputation is going to heal or not, and what needs to be done to minimize the level of amputation, and how we give a patient a functional amputation are extremely important, Kim. So, and those are the kind of things that diagnostic workup will give us so that we understand. So I don't think there's anybody out there that can argue with this one, that, every patient needs to have some kind of evaluation.
Yes, I mean, even now there might be a few except if there's someone that has an acute situation, sepsis is spreading, they might go straight to just cutting off the
Oh,
problem.
of course.
Life is on the line.
Of course. If somebody has a septic foot, of course. We are not talking about gas gangrene. We're not talking about a wet gangrene. We're talking about routine. We're talking about outpatient, CLI, we're not talking about acute limb here and, threatened limb. So yes, you're absolutely correct. We want to make sure that, that those patients, everybody agrees that, they need imminent amputation because they're going to lose their life. But for the other 98% of the patients, we need to do a diagnostic workup.
So I have one more loaded question for you. This is a doozy. So the guidelines, seem to use newer research in the last few years. So where do the guidelines fall in terms of treatment below the knee and into the foot? Now, even this summer, I had a surgeon tell me that according to 2013 data, treating below the knee was an absolute quote, and I quote, waste of time because it only leads to a revolving door of treatment. So why delay the inevitable, unquote. What guidance should patients be aware of when they have blockages in the tibials and the pedal loop, which is prevalent in patients who have diabetes and chronic kidney disease, two of the highest risk factors for PAD, and especially CLI?
So the guideline is very, very, very clear about this. Very clear. There is no ambiguity. If you have claudication, there is no indication to treat below the knee, period. If you have claudication, that is because claudication is an inflow problem. So usually the problem is in the iliacs or in the SFA, in the femoral and popliteal area. So you don't need to go and do the pedal loop for claudication. That's not going to do anything, right? So that's very clear. When you're talking about CLI, when you're talking about in patients with ulcers and gangrene, patients that need minor amputation, patients that are at risk of losing their leg, the guidelines give a class 1 recommendation on multiple different ways. Not only they give a class 1 recommendation to treat below the knee, but they say that you need to have an inline flow to the wound. So they approach this in a different ways, and they give a class 1 recommendation in all of these that you need to bring blood to the wound to be able to heal the wound. And there's no way you can do that if you don't treat below the knee. So if you just treat the SFA and the iliacs, and you don't treat the outflow, you won't be able to get enough blood flow to the wound to be able to heal it. And that's where patients get into trouble with their ulcers and end up with amputation. So you're absolutely correct. And that, the guidelines have made it very clear now that, below the knee intervention for CLI is a class 1 indication, and that we should try to bring an inline flow to the wound as much as we can.
Thank you so much, Dr. Mehdi Shishebor. We really appreciate you, and please give our thanks to the entire committee, every single person who spent, tireless hours contributing to these amazing lines that are so helpful to us. Before we go, any final thoughts, any final, any final advice for patients based on these 2024 guidelines?
Well, and my only thing is that I want to thank you for your commitment to this disease. We are very lucky to have you, Kim, and I'm very grateful to your organization for investing in our patients that have vascular disease and PAD. I am honored to participate in a format like this. Anything that can educate our patients to prevent amputation, to modify their risk, to prevent heart attacks and strokes and death, I will always step up to the plate. and work with anyone that wants to reduce the risk for our patients. So thank you so much for having me, and looking forward to working with your entire team as we continue to educate